So we wanted to talk a bit about moving. I mean, I don't think we can get away from the pandemic. No matter how hard we try, we will keep pivoting back to it. But to try and talk a little bit about some of the similarities and differences between, we've seen this phenomenal response, understandably, to COVID-19, highly infectious, lots of people getting sick all at the same time, threatening to overwhelm healthcare systems, destroy economies, etc. So not surprisingly, the response to that has been enormous. Now, I don't know what the up-to-date figures are, but during the first 6 months of the pandemic, there were about 1 million deaths. And if the global burden of disease figures are right, during that 6 months, there would have been over 5.5 million deaths from everyday sepsis. So we have this problem with sepsis, which is not really, it's not actually an ICU disease, although that's where you end up if it's bad in high-income countries. And we've all sorts of kind of protocols and mandates within hospitals introduced to deal with the pandemic. And I was going to kind of throw this to Carrie. We know that it was 40%, but now 60% of Australians have heard about sepsis, we believe, from our surveys. It kills about 8,000 Australians every year. 100% know about COVID. Why haven't we had a successful public campaign about sepsis?
Yeah, I mean, it's a great question. And we've put a lot of resource, I think, into raising awareness and educating in hospital clinicians and clinical teams. We've not put enough effort and investment into that public awareness, Simon. And just listening to Julie's presentation, I was thinking we should sit down and dissect all those learnings from COVID and think about how we use that for messaging at scale, for connecting with people to make it relevant, to look at community leaders to get the messages out as well. From a COVID perspective, we have bombarded every social media platform and we've exploited it to, I think, our benefit. One of the other things that we've learned is when you've got too much communication, people get confused and they don't know where to go. So I think it needs to be focused. But I would value, on top of where we've started in the clinical environment, to now go out and really think about how we connect with people without putting public notices in hospitals and just general practice. It's how can we actually get it out into community, Simon?
Maybe an open comment for a minute. Do you think it's the fact that we all felt personally threatened by COVID?
That is exactly what I was about to say. I mean, and the important thing is to learn the lessons, but also understand the ones that won't necessarily be transferable. And the idea that we've got a collective international sort of humanity-wide sense of vulnerability here is in part not built up by the disease itself, which is mild in young people, but by 2 decades of saying the next pandemic, the next pandemic, the next pandemic, here it is. We're all completely freaked out by this. But if on any given day I had a choice between having a Staphylococcus aureus bacteremia and COVID-19, at my age, I would take COVID-19 every single day. But the sepsis is potentially a bigger problem, as you've said, with the number of deaths. So we have to try and create that sense of maybe even vulnerability in the community, but certainly within hospitals. We've had a collective push together to get things done with COVID, and sepsis, it just gets drowned out, and it shouldn't. But we've got to find a way to have that sort of collective voice at a hospital level. And
I was going to ask Vera to comment on it. So we got these protocols and mandates, and at the moment the things around COVID are understandably extraordinarily strict. Like if you sniff in the hospital, someone's going to send you home or send you off for a test or whatever. Whereas we know hand hygiene is pretty hopeless. Should we be stricter with doctors? So doctors are probably the worst on hand hygiene. Some staff groups are particularly bad. I'm not going to talk about surgeons visiting ICUs, but do you think, should we be stricter about this? Are we to mandate people? Should we start actually jumping on people when they don't wash their hands or they don't do things properly when in hospitals?
Yeah. I think a couple of comments. I've got a couple of pictures. If I don't know if they can be brought up. Here we go. To remind me to say a couple of things on this. I took these in the Congo. And just coming back to the issue of why coronavirus would have been so successful, but with sepsis, I feel that it's fundamentally two different problems. So when we consider sepsis, 85% of sepsis happens in low and middle income countries. And it's because there are social determinants of sepsis. It's to do with prevention, to do with sanitation, to do with education, early detections, antibiotic stewardship, early treatment, and so on. And it's not a laser focus of, well, we've got this gnarly little virus, we just need to develop a vaccine against these proteins. So I think is a much broader question. And these pictures, again, just remind me that about 40% of sepsis happens in the under 5-year-olds, And another huge group is in maternal sepsis as well. So we're talking about fundamentally different sort of soup that is cooking up the problem, and it's far harder to define. And actually, to tackle sepsis prevention, which is where I think the key is in most places, you're talking about government structures and increasing people's life, quality of life, and education and so on. So I think it's very, very different. In terms of hand hygiene, yes, a quarter of hospital-treated sepsis is health care associated. So a quarter of people that end up in hospital is because we, as a medical profession, have given them sepsis in the first place. So that's a terrible, terrible thing. So I think, yes, we can't really be too overboard with 5 moments of hand hygiene. But at the same time, I was speaking to a colleague at the lunch break saying, in Australia at the moment, because of PPE, sometimes intubation and so on is a real farce if you try to do it COVID safe. It is so difficult to do it, and it might challenge you technically that you actually underperform in a population which at the moment we're at very, very low risk. So I think we need to be sensible about how far we go, and at the same time where the bang is for the buck in terms of ties, rings, watches, sleeves, your alcohol wipes everywhere. I think absolutely we can't really go overboard there, but I think we've got to be sensible in not actually reducing our performance at moments of low risk.
I wonder if, are we going to just go back to our previous behaviour? I don't know the answer to this question, but it's become socially acceptable, much more socially acceptable to wear a mask in public than it was before. It was quite nice when it was mandated in New South Wales because nobody felt like a complete plonker doing it when they went into the supermarket because you had to. So that was quite nice. And we've got all over this convention centre, we've got hand hygiene, etc. Are we just going to go back to where we were before? Julie's shaking her head, or
I don't think we'll quite go back to where we were, but these behaviours, all these new behaviours take effort, and we get confused about whether we should be doing them now or not, or it can be socially awkward to negotiate someone wearing a mask if they're getting close to, or, not shaking hands or whatever. So they take effort, and you'll always have inertia, which will bring people back to baseline and back to old habits. But I think there'll definitely be new habits that stay. There will definitely be an ongoing prevalence of mask use to some degree. There will definitely be people who are more aware of hand hygiene. But I just want to go to the point of hand hygiene in healthcare. There's a behavioural science around this. There's quite a good evidence base on what actually gets people to practice hand hygiene and other practices. And it revolves around, education, accountability audits, nudges, things in the environment. We walk through here, and what makes it easy to clean our hands? It's having those sanitisers so easy to access. Or simple things that observational research finds, like somebody has a clipboard or an iPad in their hands and there's nowhere to put that while they wash their hands. So little observations, the little details can be very useful in figuring out what you need to do to help people perform the behaviours.
Yeah, I think, so we've got a lot happening on Twitter. One thing I want to bring back into this conversation is really about mandatory vaccines. There's a Twitter poll going at the moment. Should COVID-19 vaccines be mandatory for healthcare workers? The majority, around 70%, say yes, 30% say no, and there's a 5% that are unsure. So I guess we just want to ask that question, should COVID vaccines be made mandatory? And Julie, I think you'll be able to come in here about what it might look like. But Kirill, from your experience from Yemen, what do you think about this issue? Should it be mandatory for vaccines?
Yes, in a nutshell. I think it's a bit complicated, I think, with a lot of the settings that MSF works in. Just to share my own experience, I'm pretty sure I got COVID-19, so we couldn't test at all by the time I was in Yemen for probably about 6 weeks. And I remember being very tachycardic and probably felt a bit funny and couldn't smell for 5 days. So I'm pretty sure I've got COVID-19 or had COVID-19. We couldn't do any antibody tests, we couldn't do any swabs. And it was interesting speaking to some of my colleagues who were in the field with me. And one of them actually said, I'm kind of resigned to getting COVID-19, and even if I die in the field, so be it. And that was quite extreme to me, and in some ways probably reflects some of the feelings that we have when we work in the humanitarian sphere, which is not necessarily healthy. But I think it is a responsibility, if we're able to protect the people that are working in environments and places where you are exposed to a disease that could potentially kill you. And I think for the most of us, like, we don't have risk factors, we're young enough that we'll probably get away, like I did, with just getting very, very mild form of the illness and skate through. But I treated patients who were in their 30s and who were in their 40s who died from COVID-19. And my feeling is that if you have it and you have access to it and you don't have any contraindications to getting it, why are you refusing it? Like that's as simple as it is in my mind, based on my experience. I'm sure other people would disagree.
And so, Julie, I think, what would a mandatory vaccination program look like?
Well, it would look like one that had met a set of preconditions, as I said earlier, for the vaccine, but also for making sure that the vaccine is accessible as possible. And there are some settings where equity of access is problematic. We've learned a lot with mandatory vaccination in children in Australia. And probably the best balance is to have a mandatory documentation, because that will usually push most doubters over the line, because they have to make a decision. And if they want to not vaccinate, then have an exemption signed by another healthcare professional or their manager. And then if it needs be, then perhaps they need to be deployed to another area. But if you've got a lot of refusers, you're going to have a workforce problem that you have to plan for. And as I said, right now, people are just building their confidence in the vaccine, and it's too early in most settings to require it. And if you do, you need to have careful procedures, and you need to compensate people for very rare serious vaccine injury as well, which can happen very rarely. We don't have that system in Australia, we should, and so that would need to happen as well.
Thank you.
Just, we're going to have a bit of a wrap up in a moment, but Julie, well, all of you really, but what about, should we, I mean, apart from Donald Trump, but should we censor social media? There is disinformation out there. What do we think about that? Do we just have to accept it? And
I loved it when they shut down Donald Trump's Twitter account. But I just published an article, a debate in a journal called Index on Censorship, saying, no, we should not censor misinformation in social media. It's a bit of a complex argument. I'll be really quick. there are 3 reasons. First of all, we assume that social media is having this massive influence on behaviour all the time. It's not. It's a bit more nuanced than that. There are other things that influence behaviour. Where it happens, the process is fraught, it becomes a blunt instrument, and you sort of play into the hands of the anti-vaxxers, because they're saying that government is intent on shutting us down and covering up, and then you have a process which looks like that. You interfere with people's right to freedom of expression, and the outcomes can be perilous when you do that in certain countries. So I think that's a very fraught space, but I know it's counterintuitive to say no, especially when you liked them censoring Donald Trump.
Just became quieter, really, didn't it? Does anyone on the panel think we should censor or social media? I mean, we've just seen, well-known TV chefs in Australia have their Facebook and other accounts shut down for misinformation. Is that something we think is a good idea?
Just a comment, I think, on the anti-vaccine sort of movement on Facebook. There are apparently about 425 sites that are anti-vax sites. And it's sort of interesting to me why they're there. And I think it's a matter of inoculation or a bit of education. And I get your point about it's almost sort of ignoring tantrums and not drawing attention to tantrums in children by that paradoxical advice that you give in not censoring. But about 20% of anti-vaxxers, they genuinely believe their worldview. So it's not that they've got some ulterior motive. But about the other 80% is about either selling some other quack treatment that they want to get out to the communities that would buy that, or it's for the advertising space, because in terms of humans, you'll know more, Julie, and others, no one can resist a good conspiracy theory. So we all go and read these things, and then we get sold, gym equipment or whatever that we have. So the reasons, I think, to me, that made me think, wow, if we're actually educated, but also humans like to be smart or be seen to be smart, to ignore things that are false as well, because, oh, I know better, yep. So I think it would be a matter of education of when you see things like that, and they teach children that in Scandinavia as part of the national curriculum, how to spot fake news or how to think critically about social media. And I think we should think very hard in our national policy about immunizing our children cognitively there. But I agree it's a little bit of a slippery slope, because who then does the policing of the censorship? I think that is a very, very fraught area.
Well, that's easy. That would be me.